Awesome. Well, we've all been sitting here for 40 minutes, so everybody stand up. All right, I'm not going to do the full 60 seconds because 60 seconds is too long, but everybody just stand up, do a little stretch, revitalize yourself, and then we can talk a little bit about how we manage injuries. So just some disclosures. I have no personal disclosures, but I am on the board of the Society for Surgical Ergonomics. We do have some funding from industry, all of which won't affect the contents of this talk. We all like to think of ourselves as skilled professionals, surgeons, anesthesia, nursing. We've trained for years. We're a cognitive specialty. We're really, we're craftspeople. I like to think of myself as an athlete. This actually came when I injured myself and I saw a sports medicine friend of mine, and he said he treats all surgeons like high-performance athletes because we need to have peak physical performance in order to do our job. And plus, it made me feel kind of good to think of myself as a pro athlete. In reality, we're manual laborers. We stand, we do physically arduous work with long periods of strain in a harsh working environment. We like to think of ourselves as professionals. We are essentially factory workers. If you look at OSHA's guidelines and the risk factors for workplace injury, we have almost all of them. The only one I didn't star was work performed from heights, but if you talk to one of my colleagues who's 5'1" and has to stand on 3 steps to do an operation, she's working from heights, so I should probably put a star on that one too. Not only are we in harsh working environments that any OSHA inspector would come in and have a heart attack, surgery is a unique environment. So it's not just that we are manual laborers, we're in an organic workspace that we can't control. So it's not like machines that we can replace. We have to work on a patient where they are, whether their BMI is 18 or whether their BMI is 60, no matter how tall they are, no matter how tall we are. It's time-sensitive work, and it's work that requires a high reliability. All of this, as we've heard already, has really led to a hidden epidemic of surgeons in pain. And if there's nothing else that comes out of today's session, it's that we need to talk about this more. Because if we don't talk about it, we don't build the culture that we were just hearing about. All of this leads to really a crisis. As we've heard, about 90% of surgeons are in pain within the last 7 days, and about a third or more of surgeons are in pain at any given time. Now, pain is one thing. If you're a little stiff and you're a little sore after an operation, you pop a couple Advil and you're better the next day, we all deal with that. About 40% of surgeons have actually experienced an identified workplace injury, an injury that has caused them to lose work, to take time off, to modify the way that they do operations, to think about leaving the profession, or even to go on disability. And I think all of us in the room probably know of at least a couple of surgeons, some of my personal mentors who had to retire early because of ergonomic and workplace-related injury. About half of surgeons feel that their work-related physical discomfort will affect their ability to perform surgery in the future. If you think about that just from a workplace and a workforce standpoint, that's really critical. If we lose half of our surgeons or if we lose our capacity because of these injuries, it becomes not just a personal problem, but it becomes an industry and a profession problem. This all leads to moral injury. It's not just the physical aspects, it's the depersonalization, the satisfaction, the higher burnout. And there is data that suggests that surgeons that have ergonomic injury have higher rates of burnout, callousness, depression. There was really a chilling paper presented at this meeting by Debbie Keller that showed that 50% of surgeons screen positive for depression and 80% screen positive for burnout. We're doing this to ourselves. So anything that impairs our physical condition impairs our ability to take care of our patients. We all care about our patients. It impairs our ability to care for ourselves, our teams, and our loved ones. We've already heard a little bit about prevention, and an ounce of prevention is worth a pound of cure. I put a QR code. This is a particularly good article and actually has some surgery-specific exercises for prevention that I would highly recommend. We've already talked about things like the micro breaks, the postural resets, the ergonomic timeouts. So I'm not going to go over all of this again, but really critical because if you wait till you're injured, it's too late. So what are the signs of an injury? And by this, I mean injury beyond just being a little bit of sore, being a little achy. If you're starting to wake up with pain, so if you've done a hard day and it's 2 or 3 days later, you're still waking up and your back is stiff, your shoulder's stiff, you're waking up in pain, that's a sign you've actually done physical organic damage. If you're waking up or if you're starting to develop neuropathy, loss of grip strength, numbness and tingling, this is actually quite common, and one of my own partners, the first clue that he had an ergonomic injury was actually he started to notice his grip strength was weak. Why was that? Well, he actually had a radial nerve compression. Never had any pain before that. So if you're looking for neuropathies, again, that's a sign, and these are sort of red flag symptoms. It's like you think, okay, what's a red flag symptom for esophageal cancer, dysphagia, these are red flag symptoms you need to pay attention to. If you start to notice that pain or physical limitations, stiffness, grip strength, if they're starting to limit your ability to do an operation, I actually identified my own repetitive stress injury because I couldn't grip a grasper anymore during difficult cases. My arm hurt so badly, I actually couldn't do the retraction I needed to do, and I noticed I was modifying the operation. I was modifying what I was doing, and that hurts patient safety, right? So it's not just about me, it's about the patient. And certainly if the pain or physical limitation is affecting your life outside of medicine, that's a big red flag. If you can't do the things with your family, pronto pup, if you can't do the things with your family you want. If you start to avoid things, avoidance behaviors, I'm not gonna do that case, or I'm gonna send this thing over to my partner because I can't do this anymore. If you start to feel dread, right? I'm dreading doing this operation, not because it's a hard operation. I'm dreading this operation because it's going to make me hurt. Again, that's going to influence your decision making, and that's a red flag that you're probably suffering an injury that you need to get taken care of. So what do you do when you're injured? I'm a big fan of Parks and Rec, so normally I would say treat yourself. This is a situation where you don't want to treat yourself. Surgeons and physicians in general are our own worst patients. Go get checked out. If it's an urgent issue, I've actually known surgeons that have tripped and fallen and broken things in the operating room because of the clutter that Dr. Halle talked about. So employee health, urgent care. I saw a survey that less than half of surgeons actually have a primary care physician. Who here has a primary care physician? Less than half the room, right? So get yourself a primary care physician. I personally go see sports medicine. Again, I like to think that I'm an athlete, and plus I'm friends with the sports medicine docs. Once you have a diagnosis and a plan, it's almost always going to start with PT and OT. The importance here is to stick with the program, right? The stress causes the injury, you do the rehab, and you return to normal. I want to argue, though, that returning to normal is no good, because normal is what you got in this trouble in the first place. So we need to break that cycle, because if you get in the cycle, that's what leads to disability. So breaking the cycle means finding a new normal. And that new normal are all the things that we've talked about. And most of us have come to being interested in ergonomics because of personal injury and personal issues, where we've had to learn to break the cycle. Rehabilitation, prevention, the team dynamics, the equipment you need, building a business case for institutional support. All of this is an identity challenge. And what do I mean by that? Well, what does it mean to be a surgeon if you can't operate anymore, right? What does it mean to be a surgeon if it hurts to operate? These things can take a toll. I've had a couple periods where I had to take significant amounts of time off of work, and that affected me emotionally and mentally. So get the support you need. Talk about it in public, because if you don't talk about it in public, other people don't feel comfortable talking and thinking about this. So talk to your friends, get some therapy, and try to build that culture of safety and support that we can use to build a profession that takes care of ourselves better. I want to sort of end by saying that less than 20% of surgeons report their work-related injury to their employer. Why is this important? Well, let's game this out. You're 62 years old, you have a cervical spine issue, you can't operate anymore, but you don't quite have enough money to retire, and you're trying to get accommodations from your employer, or you're trying to go on disability. It turns out there's employee health law around work-related disability, and it all depends on temporality and causality. And if you don't have documentation of a work-related injury, you cannot get this to happen. One of the surgeons in my own department is currently suing our institution to try to get disability because he doesn't have documentation that his injury, which is clearly work-related, was from work. So you got to establish that causality for workman's comp purposes so that you can get work to pay for your rehab, so that you can get ergonomics assessment and the workplace accommodations that you need. And you need that, again, to build that business case, because honestly, administration's not going to care about you, but they care about your productivity. So if you can build that business case around productivity, then maybe you can get the support we need. Although I will say, when I went to my own institution, this is what I was told, that they don't support ergonomics assessment in non-office work environments, right? So that's why I say you've got to build that business case for all of the things that we've been talking about through this entire session. So I'll finish up there. This is, I would say, when the time out and the time off, this is a happy space going fishing with my daughters.